Second is data collection status of CSCs in Broward and Palm Beach counties by Dr. Mehta. Brijesh, can you? I think this was yours.
All right, so I apologize. I'm coughing in between, but I appreciate you all coming here, taking the time, and how do I go to the first slide? Okay. So like Laszlo said, this is informal. Feel free to ask questions along the way. A lot of what we're going to said are best practices. So, this is what we do at Memorial. This is some of the data collection that we've performed. Go to the very first slide. Yeah, the title. No, I was just fixing this earlier. Okay. So I was asked to speak about our pre-hospital protocols, what we've done with EMS integration over the last 2 years and change, and some of the data collection initiative thereafter. Next slide. So we're going to talk pre-hospital scale data, the limitations, the transition to RACE Plus scale, which I think is going to be much more effective in terms of reliably identifying LVOs. And I just see myself. But have a brief Pulsera update, and that's about it. Next slide. Okay, so before we delve into that, I want to go over the Broward EMS Stroke Coalition timeline for this year. So we have just received an update from Dr. Antevi and Jeffrey Walker from ASA that the HCA hospitals have moved forward, at least in our region, signed up for the Get With The Guidelines data collection. So that's fantastic. And so the next step beyond that is going to be participation in the Florida-Puerto Rico Stroke Registry, which is the collaboration with the University of Miami. So I hope that the HCA hospitals such as Westside, Aventura, JFK, and others in the Kendall will move forward with signing up for the registry. The contact information is on the slide deck. Maria is available from University of Miami to assist those hospitals that are now in Get With The Guidelines but not in the registry to get on board. And so the goal is over the course of these next 4 quarters, we'll have concerted data collection based on the variables that we had previously discussed, the metrics, for pre-hospital, on arrival, to picture, to reperfusion, cath lab metrics, and then most importantly, outcomes. And that data will be utilized at least this year, in a blinded fashion to get a better understanding of the quality of care in our region, and starting in 2018, unblinded to the EMS medical directors. So the goal of this lecture series, as Laszlo mentioned, is to get all the hospitals up to the same quality of care delivery so that there's minimum variability as possible. And so by the time 2018 rolls around, EMS is not in a difficult situation of making, sometimes perhaps politically challenging triage decisions. Next slide. So this is just the status of the hospitals that are in the registry, the Florida-Puerto Rico Stroke Registry. And you all know, based on attendance in the audience here, who you are. So I won't go through in detail. But the latest updates are, that Aventura, Westside, and I believe JFK are now in Get With The Guidelines. And so hopefully they'll be in Florida-Puerto Rico Registry soon. Next slide. So just mentioned that. Next slide. All right. So I'm going to now talk about pre-hospital protocols, and we've gotten tons of questions just through similar talks I've given, Mark Ellis has given, Dr. Antevi, in terms of what sort of criteria exist? What have we done in Broward to set up our stroke alert mechanism to the receiving hospital? And how do we connect with the neurointerventionalists? What is their criteria, trigger for cath lab activation, and so forth? And then finally, is it truly effective? Is it worthwhile? So we have some really compelling data that will be shown for the very first time here. So stay tuned. And finally, for in-hospital workflow, if we do integrate with EMS, how do we harness that collaboration to make sure that once patients get to the hospital, that they're treated as quickly as possible? Next slide. So this is just a quick overview of our workflow. I've shown this slide before, so I won't go into much detail, and you can use this for reference at your hospital. You can borrow it, duplicate it, do whatever you want, modify it. So when we receive the stroke alert from EMS, the front line is the neurologist on call. And so when the Medcom alert arrives, or via Pulsera in the near future, basically the neurologist is notified. Then hopefully the medics have provided a RACE score. And so if the score is 5 or higher, then a quick call to the interventional team at that point. And so this is all pre-arrival, ideally. And based on the information that's gathered at that point, if the RACE score is 5 or higher, and if we have some additional pertinent information, such as are there cortical signs, case preference, aphasia, neglect, then we can more readily and confidently activate the cath lab, and especially if it's after hours, because you can imagine, you're calling in 2 techs, 2 nurses, at least at Memorial. That's what comprises our team, and so. In addition to perhaps even the anesthesia team if the patient's unstable. So that's a lot of individuals being called in after hours. So we want to make sure that we have minimum number of false positives, and that's why collecting this information is crucial, and I'll show you how we do that. Once the patient arrives, so now this is the ER phase, they go straight to the CT. And then what we've outlined as our imaging algorithm is if they have an NIH stroke scale score 6 or higher, then in all of those situations we obtain vessel imaging. So in addition to a non-con CT, we get a stat CTA of the head and neck. And that's in line with the most recent guidelines that, the importance of vessel imaging to identify a large vessel occlusion. And so once LVO is identified, ideally in this phase, if we have that pertinent information in terms of the cortical signs, then the team is already in the lab prepping, and they go straight from the scanner to the lab, and the goal for groin puncture is within 10 to 15 minutes of arrival. So now, along with NIH stroke scale score, there's always some, gray areas where, okay, stroke scale is less than 6, but should the patient still have vessel imaging? And the answer is yes. If they have fluctuating exam, let's say en route, perhaps they had dense signs, hemiplegia, neglect, and so forth. And then by the time they get here to the ER, let's say they just have a little bit of a drift and they're talking again. So in those situations, if that history is reliable, then yes, always get that vessel imaging. So fluctuating exams, just like for IVTPA, they still garner, the initial urgent evaluation with vessel imaging. So that's that. We've defined it here. For those that may not be adept to the NIH stroke scale score, what comprises generally a constellation of symptoms equal to a scale of 6 or higher. So, obviously weakness in the arm, leg, they pick it up, it just drops back down. Difficulty talking or understanding, and then the cortical signs, and then posterior circulation, that's always a conundrum. So do we want to order a CTA for every dizzy patient? No, because you're just going to overburden the radiologist and you're going to get a lot of normal CTAs. So we combine it with drowsiness and or ataxia in order to increase the pretest probability of a potential large vessel occlusion. And so these are signs and symptoms that correlate to posterior circulation compromise. Now let's say if the stroke scale is less than 6 and en route they didn't have any fluctuating exam findings, on arrival you're confident that, this is a non-disabling exam, meaning that they just have they can pick it up, maybe just a little bit of a drift. Same thing with the leg, for instance, they're otherwise coherent. Is that enough to warrant thrombectomy, even if they did have a large vessel occlusion? So it depends on the center and the aggressiveness of the neurointerventionalist, right? Based on the data, however, it's not supported. So I would say that's still a gray zone in terms of, whether you should take a LVO with minimal neurological deficits to the cath lab, because there's always a chance you can make things worse. So in those situations, working with our radiologists, what we've done is, look, we will still get the appropriate imaging, but instead of a CT, CTA in every patient, which radiologists, always balk at for appropriate reasons, radiation dose, contrast-induced nephropathy, and, doing a scan for perhaps, unnecessary indication. So a brain attack MRI is not only going to show you the acute infarct if it's there, so rule in or rule out, is this ischemia or something, a stroke mimic? And the vessel imaging, so we set a time frame of 4 hours. So that means, look, if the exam has minimal deficits, that's not a patient that I'm going to rush to the cath lab anyway, because even if they have LVO, that means they most likely physiologically have, robust collaterals. Then let's get that brain MRI and make a more informed decision in terms of what to do with that patient. So does that make sense in terms of kind of segmenting out a CTA versus MRA and the criteria to obtain each? And that cutoff for NI stroke scale score is based on the current guidelines and extrapolated from the clinical trials, which is, 6 or higher were the patients that were taken for thrombectomy in majority of the trials published. Okay? Because that equals disabling exam. And those are the patients you don't want to miss an LVO in. Okay? Any questions? Okay. So we call this the nitro workflow. My wife always makes fun of it. She's like, you're crazy. So I said, look, NITRO stands for neurointerventional thrombectomy, recanalize occlusions. And she was like, you're stupid. So I added rockets for good effect, just to indicate that you got to move with, sense of urgency. Okay, next slide. All right, so this is kind of, from this point forward, I'm going to show you a lot of data. If you can't see it, you can, refer to it later or just ask questions I can explain. Sorry. Hello? Yeah. Okay. I'm in the middle of a talk. Is there something I can call you back in like 30 minutes? Okay. All right. That's okay. Could you call Dr. Duong? Okay. All right. Bye-bye. Okay.
I apologize for such interruptions. We are physicians, number one patient. And actually, it's a very busy season, in Florida. So we got multiple strokers today.
Yeah, it's been pretty crazy. So we created an EMS dashboard, and so this is, some additional data sets that we can provide to all the hospitals in the region in terms of templates on how to go about collecting the information. So what this is meant to do is to show EMS that, okay, the information that they're providing us isn't just going into thin air. We're actually collecting it and then trying to give feedback so that they can improve their, pre-hospital assessments. So this is month over month, so this is all of 2016 for which we had data available, and this is all the EMS agencies referring to Memorial. And what this shows is the percentage of stroke alert utilization by agency. So anytime a EMS agency calls in a stroke alert, we're collecting that in our data set. And then we can go back at the end of each month and say, okay, Hollywood Fire Rescue, for April 2016, of all the stroke alerts that were found to be actual stroke alerts on arrival, you called in a pre-alert 91% of the time. Does that make sense? So because on arrival, our ER physicians are doing their own assessment. And if they realize, okay, this is a stroke alert, but you guys didn't call it in the field, then that's a fallout for the medics, right? And so that's basically the denominator is the total number of stroke alerts called in the ER, and the numerator is the number of those that were called from the field. So we want to match 100%, okay, in terms of the compliance. So that requires ongoing education with identifying, recognizing stroke signs and symptoms in the field, especially, sometimes it could be, misleading and say, patients found down and it's a trauma, but in fact, as we see many times, it's actually, the stroke symptoms that cause a patient to fall, hit their head, laceration, and so forth. So, our goal is to give each agency feedback, directly on a monthly basis for stroke alert utilization. So next slide. So now, with the layer of using the RACE scale, what is the usage of the scoring mechanism and communicating that among the stroke alerts that are provided? So that's what this slide shows. And this is all a virtual dashboard. Memorial purchased a software called Tableau. And so we're not manually, crunching the data for this analysis. The data goes into the software by our quality analyst, and then these charts are generated based on the questions we want to ask. And so it's pretty amazing, actually, and we're one of the first service lines in the hospital to use it. So this is month over month, and the number of stroke alerts, so that's the yellow bar. So that's the N value, so it's the absolute value, and the percentage are the frequency with which the RACE score was provided. So we have 70 alerts in September. These are all agencies for which we had data at regional, and among those 70 alerts, almost 70% had a RACE score provided. So does that make sense? Okay. So, we also want that to be up to 100% as much as possible. So if you have a stroke alert in the field, then please, assess them and calculate the RACE score and call that in addition to any other pertinent information such as blood thinners, last seen normal time, and your ETA. So many times, we have EMS call in a stroke alert, and they're literally 5 minutes from the hospital. So if you can educate your crews to do that as early as possible from the time you assess a patient at their house or nursing home or wherever, so that at least it gives the receiving hospital some time, especially after hours, to get their teams in. Next slide. Okay, so this is I think, the slide and the data that people have been wondering about. And so I apologize if the numbers are too small, but I'll describe it to you. So basically, we did our analysis, and this is hot off the press, and hopefully will be published by end of the year. So for 2016, since we were one of the first systems in South Florida and maybe around the country to utilize the RACE scale, we went back to our data sets and we said, of all the EMS patients, all the stroke patients, brought to Memorial by EMS, let's see how many of those were, called in as a stroke alert pre-hospital versus not. So that was step number one. And if they were called in as an EMS stroke alert, how many of them had a RACE score, accompanying that? And then when they did, what did we do downstream, right? Because, Mark Ellis, Dr. Antevi, we, give these talks around the country where we get asked similar questions. What is the, false positive activation rate for the cath lab? Does utilizing a RACE score make sense? Is it reliable for predicting LVO? Because, there's that one study out of Spain, but since then, there hasn't been a prospective real-world data utilizing RACE score for actual downstream trigger of the team, cath lab team, et cetera. So basically, we had almost 1,000 EMS stroke alert patients, of which, I would say about 65% had a pre-hospital stroke alert, so we'll focus on this first. So of those stroke alerts, a good number had RACE scores provided. So I saw you guys were falling asleep, so Laszlo did that intentionally. So, yeah, I love data, so if you fall asleep, that's an insult. So, of the number of patients with the RACE score, now if you look downstream, how many with a RACE score less than 5 had an LVO versus not LVO, right? So this is really compelling. If the score is less than 5, basically 383 patients did not have an LVO. So that's good news. So that means that, we're not missing potential real deal patients if the score is less than 5 and, by not activating the cath lab and so forth. So now if you look at score 5 or higher, and this is where things get a little, muddy, because if we want to actually activate the lab and move quickly, then does it make sense to just use a numerical cutoff, or us being clinicians, should we also utilize some additional criteria such as presence of cortical signs? And there's a recent paper in JNIS that came out on the VAN score, and it basically goes along the line of what we implemented at Memorial, which is let's utilize the presence of cortical signs as the trigger for cath lab. So let's say Randy Katz is in the ER, and he calls me and says, Brijesh, I have a patient with a RACE score of 6. My next question is, do they have gaze, aphasia, or neglect? And if he says yes, then even before the patient gets loaded into the scanner, I tell Randy I'm going to activate the cath lab. Okay? So that's this pathway right here, everything in red. So 45 patients out of 65 had a score 5 or higher with cortical signs. Okay? So those patients, out of 45 patients, 35 were found to have a large vessel occlusion. Here's the good news. Only 10 out of those 45 did not have an LVO, okay? And then moreover, if they didn't have cortical signs, then basically no patients had LVO. So that goes along with what was found in the VAN scale study, okay? So, yes?
So, Dr. Mehta, so out of the 65
Yes. 5 or higher.
45 of those patients were LVOs.
35. 45 had cortical signs, meaning gaze, aphasia, or agnosia. And then when we scanned them, 35 were confirmed to be LVO.
LVO.
Yeah.
And how many of those received a medical thrombectomy?
Right. So of those 35, 27 received mechanical thrombectomy. Okay. So fairly high percentage. And 8 did not because the stroke was too large, or, their exam improved, or, they had a bad baseline modified Rankin scale, and so the family declined. So there's a multitude of reasons, right?
Mm-hmm. So now,
but majority of them receive mechanical thrombectomy based on our selection criteria, which we'll go through in other lecture series, such as CT aspect score 6 or higher, and NIH stroke scale score 6 or higher, and so forth.
So,
yes. Right, so that's a great question, and I was discussing that with Randy, and we, for a time modified our cutoff for activation of the cath lab to 7, 8, or 9, because and there's a recent study that's published in stroke, the International Stroke Trial Registry, where they analyzed the predictive value of LVO based on these scales, and they found that for race. A 7, 8, or 9 is highly predictive of a large vessel occlusion, not 5 and 6. Okay, and I'll go into why. Yeah, so I think it's clinical judgment, right? So if EMS is communicating in addition to a race score, the actual components that we care about, mainly the cortical signs, then that's what I rely on, and not necessarily a number, right? Because this is also a new thing for EMS, and they may miscalculate the score based on the components that they're assessing. And if they don't have the experience, they might get a score of 4. But when you press them and say, do they have cortical signs, and you ask them, inquire that, if they say yes, then you have to generate some doubt that, okay, score's probably not a 4, it's probably a 6 or 9. Yeah.
Basically, what they propose is the van as opposed to the race or
Right.
scale. So it seems from what you're saying that you were actually using, right?
Correct. So cortical signs for cath lab activation. The reason I like the race scale more than van, and we actually tested this at the EMS World Expo, Mark Ellis, Dr. Antevi, and I, basically 30 people in the audience, all from EMS. We broke out into different sessions. We had the race scale session, van, and fast ED, and people overwhelmingly liked the race scale the most in a survey. After they tested out each, we did some mock simulations and so forth, and the reason being is they said that the van didn't provide enough information. It's just a positive and negative, right? By the end of the day, if you have a van negative patient, that still should be a stroke alert because they can still be eligible for IV TPA. If you think about the overall population of strokes, and the subset that have LVO, it's a quarter or less, okay? So let's not forget about patients potentially eligible for IV TPA. So RACE not only assesses patients that A, are suffering a stroke, and then B, beyond that, who have a LVO. So, and then it's the severity, right? All these scales, just like the NIH stroke scale score, a scale of 10 on the NIH stroke scale versus a score of 10 versus a score of 30, clinically, as a neurologist or neurointerventionalist, gives you a different idea of the sense of urgency with which you should move. Because a 30 and a large vessel occlusion means significant hypoperfusion versus a 10 with the LVO. So similarly, and the race has been shown to correlate with NIH stroke scale score. If it's high, then I'm going to mobilize faster than if it's a score of 4, with cortical signs. Does that make sense? And that's exactly what the feedback was from the people at the expo is, a numerical value, plus having that added information of, cortical signs, which the van specifically assess, is useful.
If I can add to that, you have to remember also from a pre-hospital standpoint, we need to have a scale that also looks for TIAs, for small strokes. It has to be an all-inclusive scale. While VAN itself may be a reasonable scale for looking for large vessel occlusion, it's not going to help us pre-hospital to identify the small strokes, the TIAs, the other neuro problems that we still have to look for. So we need that all-encompassing that covers everything scale, and that's why RACE still seems to be the best scale, at least for us, because it does cover all the smaller strokes and allows the stroke alerts that are not large vessel occlusions as well.
Yeah, it's a great point, and I'll show you data on that in terms of impact of these stroke alerts on door-to-needle time as well as puncture times. So just to finish up with this slide, yes, Ritesh.
On the same slide, so 65 races are greater than 5. Did you have to call, and let's say if all those 65 came off hours, would you have to call in the cath lab for all 65?
No, so that's where I'm going to now point out the phase at which we activate. So all the stuff in blue, so when the EMS calls in an alert to the ER, or they FaceTime me, that's the neurointerventional alert, okay? So that's just, okay, we have a patient with a score of 5 or higher, all right? And then we ask some additional questions. And then they get to the ER, and the ER physician assesses the patient. If they're found to have cortical sign, and at that point they update me, it's at that phase I activate the cath lab, okay? So once I get verification or confirmation from the ER that, yes, my exam agrees with the EMS exam, all right? I'll tell you what we want to move to in the future to combine these two phases with the RACE Plus scale. Now, once they're in the ER, you have presence of cortical signs, I'm more confidently activating the cath lab. Now they're in the CT, and we have a positive LVO confirmed. At that point, I'm updating the team, who's now in-house already at 2 in the morning or what have you, that, okay, it's a go, patient's going to come up in the next 10 minutes. And then they get treated, all right? Does that make sense? So we want to filter out, just like Kelso asked, those patients who have 5 or higher, narrow that to those who are high probability LVO.
Let me volunteer this for a moment. Whoever has the microphone has the right to go, okay? And I deliver the microphone.
You can
Question, Dr. Mehta. Quick question from
Yes.
the time EMS calls you,
Yes.
what is the time lag from when the ED physician tells you he believes it's a LVO?
Right. So that's what I was getting to before. The earlier the crew calls in the EMS stroke alert, ideally it shouldn't be called in as they're like rolling into the ambulance bay, right? Otherwise, there's not much time difference, and it really doesn't make sense to call in a pre-hospital alert at that point. Where it helps is if they call immediately from the field after their assessment, then on arrival, the ER physician's assessing the patient, confirming or disagreeing with the exam, which can happen. So that time difference we've looked at. So from field to ER, the median time is, I think, like 12 to 15 minutes. It's not that high. Because, the agencies in the catchment area around Memorial, and similar, I bet, to your hospitals, is fairly saturated, right? And so from pickup to coming to the ER, that distance is not that high unless you're encountering traffic.
Dr. Mehta, can I ask a quick question?
Yeah.
So it seemed to me that the biggest benefit for the pre-notification by EMS was to actually get the whole team ready, right?
Yes.
But now it seems that even though there was pre-notification, they would be talking to you, but the decision actually to activate the rest of the team doesn't happen at Memorial Hospital until actually the patient hits the ED, right? So
Right.
and only then after you find out that there's cortical signs. So you're kind of losing that benefit.
Yeah.
It seems.
So it's a good point, but when we tried just implementation of that type of protocol with a race 5 or higher, we were getting a lot of false positives, right? Because if you look at if your racer's 5 or higher, but there's no cortical signs, that's an additional 20 patients for which I would have activated the cath lab necessarily. Okay? And so at the end of the day, we went back to the drawing board and we said, if from field to ER arrival is only, median of 10 to 15 minutes, then when the exam is confirmed on arrival to CT scan is about 10 minutes, okay, door to picture. And then additional CTA takes probably another 5 to 10 minutes minimum. So that entire phase of the ER from arrival to CT to CTA completion is about 25 to 30 minutes, okay, give or take. It can happen faster, but if you have IV access issues, if the patient's unstable, if there's blood pressure issues, you have to lower the pressure and then give IV TPA. I mean, there's all sorts of scenarios. That 20 to 30 minutes is enough time for me to activate my team. They're given 30 minutes to drive into the hospital when it's after hours. So by the time they're completing the CTA, the team is already in-house and setting up. So once I have a confirmation of LVO, the team's ready to receive the patient. So at least, every hospital is going to have a different process, but we found that that works best for us and minimizing the number of false activations. So I myself, and I think many of you have asked me this question, when do I drive in if it's after hours? Am I driving in for every patient that has a score of 5 or higher? No. I wait until the cortical signs, that exam is available to me as a confirmation from the ER physician. Then the patient gets a plain CT to rule out a bleed, because that's step number 1, right? Is you want to make sure this is not something else or a seizure, et cetera. Once a bleed is ruled out, that's when I leave my house at 2 in the morning. So I live about 20 minutes away from either hospital. So while they're getting the scans done and then that CTA, my team is already there because I've already activated them preemptively on ER arrival with the confirmation of cortical signs. But I don't leave the house until I have a scan that shows a positive LVO. And in that workflow, our door to puncture times, as I'll show you, are extremely low. Yes. Yeah. Right. Right. Yeah. So it's a good question. some of this is still in the research phase. So, for instance, Rapid, I know a lot of folks are using it because of the FDA clearance as a standard of care for evaluation of stroke patients with LVO. We're currently limiting Rapid scans to patients who may be eligible for the DAWN trial, because if I have a non-contrast CT with a favorable aspect score and a CTA, whether you're using multi-phase CTA or just your regular CTA, one run-up and then looking at it, assessing collaterals, unless it's a complete wipeout malignant profile, I don't see an additional need to do perfusion or MRI. You have your aspect score on the plain CT. You can even do aspects on the CTA, but it's the malignant profile that's most predictive of patients having unfavorable outcomes. Anything where they even have some collaterals present, and we did this study in Boston, is not predictive of bad outcomes. So if you have hypervascularity compared to the contralateral side versus just the vascularity is down just slightly, that's not necessarily predictive of an outcome. It's the malignant profile. And I actually had a patient like that last night. Yeah. Yeah. So beyond 6 hours, so okay, if you're looking at wake-up strokes, unknown last seen normal time, my approach, and again, I'm biased, but it's still non-contrast CT. I believe in the aspect score for that, as well as doing a CTA, and then evaluating the collaterals. And if the aspects is favorable on the plain CT, and if they're 12 hours or unknown last seen normal or wake-up stroke, and we find that they're not eligible for the DAWN study, I don't do a rapid perfusion in those situations. We take them straight after a CT CTA. We only do MRI, and this is, again, limitations of our different systems. Our MRI scanner is outside the ER, a mile away from the the acute area of the hospital. So from a time process perspective, it makes no sense to me. But when we do have to get it, we limit it to a DWI in situations where the aspects is borderline, like less than 6. Does that answer your question?
Yeah. We're still relying on, I think, especially after 8 hours.
Yeah.
I agree.
Selecting your patients, and you want to get patients into the cath lab as rapidly as possible.
Yeah. And, it's one of those situations where, and Mayank Goyal talks about this when he, educates folks on process efficiency. How much information is enough, right, for you to be comfortable taking that patient for thrombectomy? And for me personally, and based on experience and outcomes, it's a favorable CT aspect score, like you said, and a CTA that, as long as it doesn't show a complete wipeout. So last night I had a patient that, we did the CT. We could have gotten the CTA, but she had IV access issues. She had an ICAT hyperdense sign on the CT, the plain CT. She's 75 years old, last seen normal 30 minutes prior. And so I said, okay, CT aspects is favorable. It's an ICAT. Let's just take her because we can't get IV access right away for a CTA. I really wanted it because I want to assess collaterals. Guess what? We reperfused her within the hour, and this morning on MRI, she had almost entire hemispheres out because she's a rapid progressor. So she was hypotensive. She had diabetes. Just a lot of comorbidities. So not your healthiest 75-year-old. And that's where I think, in hindsight, a CTA, if we could have done it, would have shown probably a malignant profile.
What is the possibilities of training in paramedics and EMS staff to shorten that time period and do the RACE score plus, doing what the ED doctor is doing, and activate the cath lab from the
Yeah, so I'll go into that
Okay.
in some subsequent slides in terms of what we're transitioning to, aiming to. So does this flow chart make sense? And, I'm a visual person. I don't know how you guys analyze data, but we put this together quickly this week in order to understand what's happening with our patients, right? Because at the end of the day, if you have protocols in place, and you're trying to be consistent and minimize variability, then becomes a very robust data set. And I think this is compelling enough to argue that, look, if you have a race score that's high and you have cortical signs, that should mean early activation or at least early alert to the neurointerventional team. We've received some concerns from folks elsewhere that, look, do neurointerventionists, should they be bothered that early in the process, pre-arrival, upon arrival, versus let's wait until that patient is fully packaged with CT, CTA, CT perfusion, and only call me at that point. And I think based on the numbers I'm going to show you, it makes total sense, without a doubt in my mind, that you should be involved in the pre-hospital or at least pre-imaging phase for potential LVO patients. And if not, then interventionalist, then at least at a minimum, your stroke neurologist. Okay. Next slide.
We should speed up a little bit because...
Okay. Yeah, I'm almost done. So can you move that picture in picture? So basically, what's the impact of stroke alerts on treatment time? So we analyzed, again, for 2015, 2016, once we had this parallel process. So for door to needle, when there was an EMS stroke alert, so about 90 patients compared to no EMS stroke alert, for 167 patients, door to needle time is 32 minutes when there's a stroke alert, 46 minutes when there is not. So a 30% reduction in door to needle time when you have a stroke alert. That's in line with all the published papers out there and the ASA target stroke guidelines that you should involve EMS in your stroke process, right? Because they found that, door to needle times are reduced when EMS calls in ahead, just like they do for STEMI. So that's not rocket science. It just validates, what others have done. But this is important. So thrombectomy, door to puncture. So what's the impact of EMS versus no EMS stroke alert? So 120 patients versus 44 patients where there were no stroke alerts. So these are all patients that went to thrombectomy. So when we just analyzed it at that first phase, 72 minutes median door to puncture time when EMS called in a stroke alert versus 95 minutes when there was no stroke alert, okay? But can we get even faster using parallel workflow and early alert / activation of the cath lab? So of these 124 patients that had the alert, 43 patients for whom cath lab was activated pre-imaging based on presence of some of the clinical findings, cortical signs. In that subset, door to puncture time was 65 minutes. So now you compare the two extremes. No EMS stroke alert, 95 minutes, EMS stroke alert plus cath lab activation pre-imaging, you're down to 65 minutes. So that's, a reduction by 20%, okay? So I don't know about you guys, but when the data shows from all these randomized control trials that for every 30-minute delay in time from door to, treatment or onset to treatment, reperfusion, the likelihood of a favorable outcome decreases by 16 to 18%, that's a big deal. Well, what's 65 and 95? What's the difference, all right? So if that's your family member, what would you want, okay? So if you're going to go through the extent of, getting in, doing a minimally invasive procedure, treating that patient, why not have a protocol in place to achieve the best outcome possible? So that's, in a nutshell, what I have in terms of, the basis for what we're doing. And I think it's fairly robust, and I hope that you guys will adopt it at your centers. So how about, reproducibility, right? So, okay, you guys are doing this at Memorial. Can we reproduce this at our own hospital? Well, we do that in our own system. We have Memorial Regional and Memorial West. So 113 thrombectomies in 2016. So Memorial West, if you look at door to picture, picture to puncture, puncture to reperfusion, there's no statistical significance, okay? So we have the same protocols at both centers, different staff, but everybody works in parallel. Next slide. And people say, okay, well, I'm still a naysayer, so what about outcomes? Okay, so we looked at the subset of patients that matched all the Mr. Clean criteria for thrombectomy. And so here's the Mr. Clean control arm. 19% of patients who achieved a modified Rankin of 0 to 2 in 90 days. In their treatment arm, it was 33%. In the memorial cohort is 42%. And so these exclude wake-up strokes, unknown last known well time, those types of patients. We limited to those that matched, all the inclusion for MR Clean. All right? And I can promise you that we would not have achieved these outcomes without a rapid process. Okay? And so that involves EMS. And so, at the end of the day, people want to see data and numbers. So this is it. All right? And so when we go back to our respective hospitals after this and tomorrow, there should be no doubt in our mind that this is what we should be doing. So now let's revisit the RACE scale. So I told you about cortical signs and the reliability of that to predict a large vessel occlusion. So this is from the original paper. I bracketed out what the cortical signs are and then the motor functions, right? Face, arm, and leg. Next slide. So what are the pitfalls for the RACE scale, right? So none of these scales are perfect at the end of the day. So for the RACE scale, it basically lateralizes, the agnosia and the aphasia. So let's say the patient has left-sided weakness, it only asks you to test for agnosia. If they have right-sided weakness, it only asks you to test for aphasia. You can't test for both. So that will invariably underestimate the overall score, and you may very well get a score of 5, and they have a large vessel occlusion, and they have aphasia and agnosia. The neurologists in the room, you all very well know that you can have both of these cortical signs. It's not isolated to just the parietal lobe for agnosia and the frontotemporal lobe for aphasia on the left side. So that's one issue. The next is it doesn't fully evaluate aphasia. So if you're familiar with the scale, it only tests the receptive component. Can you follow commands, make a fist, close your eyes, etc. It doesn't ask you to say anything, right? So how do you test for aphasia? What if they have, mixed or isolated expressive aphasia? Again, you're going to miss a cortical sign, and that may underestimate the overall score. And then finally, and this is my biggest issue with it, it weighs the motor symptoms more than the cortical signs. So you can have a capsular stroke, just internal limb, and you can have face, arm, and leg weakness, lenticular striate, and basically have a score of 6. And, what does that mean? If they don't have cortical signs, am I going to activate the cath lab? So that's why inquiring for the clinical deficits is key. The next thing is gaze preference, like in that stroke study recently that came out. Gaze is most predictive of LVO, of all the cortical signs. And it's only weighed 1 point. So it gets less weight than the motor symptoms, okay? So all of this, you can have a score of 5 or higher, and people are using these scores for different mechanisms, right? Either to triage PSC versus CSC, or if they're going to a CSC, early lab activation or early notification to NI. So in our situation, you'd be overutilizing a lot of resources if you limit it to just a numerical score without inquiring about the specifics. Next slide. So again, reference to the VAN score. So this is what I liked about the study, even though it doesn't attach a numerical score. It found that when patients are VAN positive, it's highly predictive of an LVO. When VAN is negative, 0 LVO. Okay? So I think that's pretty strong in terms of cortical signs being the key factor. Next slide. So we transitioned over the last couple of weeks after discussion with all the stakeholders, EMS agencies in Broward County, to the RACE Plus scale. Okay, we're going to introduce it, stepwise. We're going to do a podcast with Miramar Agency, Tim Roche and his crew, in the next couple of weeks. That will be available for viewing online in terms of how EMS should evaluate, patients. What are the pitfalls? And then utilizing this modified, just slightly modified RACE scale. So by that, what I mean is we've highlighted the cortical signs specifically in blue, so gaze, aphasia, agnosia. And if patients have these cortical signs along with the score, EMS will be instructed just to add a plus next to it. okay? So you don't even have to, from an ER standpoint, make your job easier. Hey, does a patient have aphasia, agnosia, or gaze preference? The EMS will tell you, hey, it's a 7+, right? So it's going to be a, quick communication to the ER. And in addition, we added a evaluation for expressive aphasia, all right? So name 2 objects, repeat the phrase, today's a sunny day. Simple as that. If they can't do any of that, then that will garner a point. So that will pick up any type of aphasia in that situation. And agnosia, we overall left it unchanged. So, this I think will be highly effective. I'd love to have your feedback, but this is from now a year and a half of experience, and knowing what we use it for. I think moving forward, this makes sense to me. Any questions?
What's the experience with the EMS guys now in terms of the
Yeah, so we haven't rolled it out to all the EMS agencies, this modified scale, but we did get feedback from Miramar, Davey, and others. Basically kind of field tested it with Mark Ellis and his crew to just say, is this going to work for you guys? And the feedback was yes. Okay, because it doesn't overall change the fundamentals of the scale. It's just if you have cortical signs, just add a plus next to the score. So it's more of a communication, thing. Next slide. Okay, so yeah, go back to that slide. So I'm glad you asked that because, in any of these scales, whatever you guys decide to use in Miami-Dade, FAST-ED, or whichever scale, just keep in mind, based on our experience in Broward, that the scale is as good as its examiner, right? The person performing it, okay? So if you have no experience and you're just doing this, you're going to encounter a learning curve, okay? So don't expect on day 1 with FAST-ED that you're going to pick up every single LVO. We went out and educated folks on the RACE scale. We had that training video. We're going to make another one for RACE Plus. And so it's going to take time, but I think overall, this is what's necessary, in order to get the right patients to the right center and affect the in-hospital efficiency. Yes. Yeah, so basically, your question is how will we utilize the new scale if you add a plus next to it? So it's a great question. So now if they call in that, it's a 7+ and it's after hours, and they call me and, say, if Randy says, hey, patient coming in with a 7+, then that way I can more reliably activate my team. So my hope is we can get door to puncture in less than 65 minutes. So more recently, we've been, door to puncture times have been 45 minutes. 2 days ago, it was 35 minutes. So when you have reliable information, your times will get shorter. Okay? And, for interested in doing FaceTime or using other types of telemedicine, we're still using FaceTime, and with the plus mechanism, anytime there's a score with a plus next to it, they'll be advised to FaceTime me, and I can then more reliably say, okay, I agree with your exam, or I disagree. Ritesh, with your experience and what you're going to be doing in Miami-Dade, it's critical that you put yourself out in front of EMS, because at the end of the day, we have a lot to educate them about, right? Simply reading the scale and performing the exam is not enough. In real-time scenarios, through FaceTime or other telemedicine, assessing that patient while they're in the ambulance, the medics I found, it's very effective, very educational to them. And, people are afraid, oh, does Mehta FaceTime with every single stroke alert? Hell no. It's like now it's once in a blue moon, because we had the ramp up where we did the education, and now they're comfortable with it. But as we make some tweaks, we're always available. So it's not so ingrained in the protocol that you have to FaceTime, but at least they know that we're available if they need guidance. Right, so we haven't formally rolled it out in terms of, we're going to do the video and then roll it out probably by end of March or March 1st. Yeah, to all the agencies. Okay. So again, as Laszlo said, this is our workflow. I don't expect you guys to, follow it verbatim. But if you find some parts of it that are helpful, please use it. It's worked very well for us. And, at the end of the day, we're here because we want to do what's best for our patients. There's no competition in this forum in terms of we're better than thou. So this is meant to be educational and collaborative. Any questions? Yes.
So, I think it strikes me that, the big delay is when the team's activity. If they're engaged, and the teams are already there, so we know they're running. I'm wondering what you think about Dave Broward, about having a designated night session, where we think of that person that's in the hospital, focus all of the, EMS students, night and travel time is much quicker anyhow.
All right.
And again, no one wants to spend the night in the hospital, but it seems to me that probably where we would head.
Yeah, I mean, I think that will solve a lot of issues, at least for our system, and we've explored the idea. There's been some pushback from the cath lab staff because, at the end of the day, it's their lifestyle also. And so I think it still requires more discussion and thought. But, if a center is busy enough and there's enough volume between STEMI and stroke cases, then overtime pay from a financial standpoint is also justified.
I think the other thing is the trauma center.
Yeah, I mean, the rule of 30 minutes, that's why it's there, both for physicians and any other emergency staff. But, always having an in-house team, you can't beat that. I would love to have that. Yes?
Are you talking about stroke intervention or stroke alert per day or per week or per month?
I mean, it's a good thought. I think at the end of the day, the issues that, from a practical day-to-day standpoint, that I think we may encounter is, if you have your elective cases, your EMBO cases, and then you're, expected to cover another hospital for that week or for that specific day, how that would work out with, patients that you've scheduled from the office. I mean, and maybe in the future you can block out, a week or a few days at a time when you're expected to cover multiple hospitals. The more significant challenge, and I think the elephant in the room, is from an administration standpoint, right? Because you have HCA hospitals, Tenet hospitals, Memorial System, at least in Broward and Cleveland Clinic. We've, broached this subject with our administration before, helping out you guys at Cleveland Clinic, and we received some significant pushback because there's monetary issues and other things, politics. So from a physician perspective, yes, I'm all for it, but I think it's the administrations that would be a challenge.
There's actually two elements in the room. So fire rescue is the other element. So just because you have a hospital, and we'll say Memorial Hospital, for example, decides to have 24/7 interventional coverage, and they're open after hours, that does not mean that Coral Springs Fire Rescue is going to drive all the way across town to Memorial just because you have 24/7 coverage. So you're going to have a lot of logistical issues with that idea because some agencies across the county are not going to drive across county to go to your 24/7 coverage.
In my opinion, the ideal situation for interventional radiologist or neurointerventionalist would be to form a group in Broward, one group, all physician, and then cover various hospitals. You know who know me for a long, I had this dream very long time ago. But so there would be someone as a first call, someone as a second call, someone as a third call, and whole Broward County could be covered very quickly because the county is small, and there would be a life for neurointerventionalists. For political reasons, this will never happen though.